And talking a little bit earlier today with Caroline Dowsett, who's doing her PhD on wound bed preparation education, I hope within the next year you'll see from her research that education of wound care providers in the principles of wound bed preparation hopefully will actually improve wound care providers' understanding of how to properly treat a wound, and also patient outcomes being improved. So I'm going to very rapidly go through these four components. Because of time, I'll just rapidly go through it. But the T realizes for tissue, there are multiple ways to remove the non-viable or deficient tissues, these barriers to wound healing. And when wounds, particularly diabetic foot ulcers, in this case from David Steed's data, are properly debrided, whether they are treated with conventional approaches or they are treated with the recombinant platelet-derived growth factor shown in the circles, both types of patient treatments become improved. The more you debride the wound properly, the better natural healing occurs, and the more effective the exogenous growth factors become. And that is really because you can't put growth factors into a hostile molecular environment. They just get chewed up. The cells don't have receptors, the matrix is degraded. Adding PDGF into an improperly prepared wound bed does no good. But when you convert that chronic wound bed into a pseudo-acute wound bed by appropriate debridement, now the growth factors do what they normally do in an acute wound, that is, they promote healing. Infection inflammation is one of the key aspects in wound bed preparation. It is essential because in data from Gary Sibyl's group, for the first time really showing in chronic wounds, that the amount of healing over time is increased, or in this case, the area of the wound decreases when the wound has either no colonies that can be detected by biopsy or less than or equal to 10 to the 6th per gram, compared to wounds that remain above 10 to the 6th per gram. Now remember, 10 to the 6th per gram originally came from burn wounds, not from chronic skin ulcers. So this is an important piece of data that Gary has contributed, relating that data from burns now back into chronic wounds for the first time. So clearly, controlling inflammation and infection is essential. Even low levels of colonization now appear to be able to retard healing down to approximately 10 to the 3rd grams per bacteria per gram may actually be able to slow healing. M, in the time acronym for moisture balance, you know these types of situations much better than I do. Not too wet, not too dry. When you convert a macerated wound into a wound bed that's properly balanced in moisture, the natural healing process proceeds. Edge. How do we know when we have wound bed preparation, the principles of wound bed preparation applied appropriately? One of the keys is to look at the edge of the wound. If wound bed preparation principles have been applied properly, then the epidermal cells at the edge of the wound will begin to migrate, and you can trace the edge, or you can visually assess the ability of the wound epidermal margin to migrate across the matrix and begin to heal. So clearly a failure of the epidermal edge to migrate indicates that the wound bed is not prepared correctly. It is not able to undergo the next sequential stage. All right, so how do we apply wound bed preparations? In the clinic, there are two new concepts, two new aids for you. One is the wound bed preparation algorithm, again by Gary Sibyl. And this is an important concept in being able to translate these sort of abstract, esoteric concepts down into the care of the patient. So as Gary emphasizes, a person with a chronic ulcer, you must first treat the cause and you must address patient-centered concerns. And that culminates then, or focuses in, on local wound care. And in that local wound care, you must address the four components of time: the tissue, the infection, inflammation, moisture, and then by monitoring the edge to see if this is appropriately applied. When the edge is not migrating appropriately and you believe you have accomplished the appropriate levels for these other three components, then, as we'll see in a second, you need to think about using advanced wound care adjuvant therapies, and we'll look at several of these. So how do you assess if wound bed preparation has been done appropriately? Again, Gary recommends looking at these assessment tools for tissue, infection, moisture, and edge. In tissue, you're looking at the clinical types of properties that you're well familiar with: color, tissue perfusion, transcutaneous oxygen perfusion. Infection, you're looking at temperature, odor, color, pH. And as I would indicate, many times it now appears that although the wound doesn't appear to have these classical signs of infection or inflammation, reducing the level of bacterial content down to even lower levels appears to oftentimes help progress the wound. Moisture, you're obviously looking at maceration or desiccation, late volume, transepidermal water loss, and then the edge, multiple ways to try to assess if the wound bed is migrating properly. So what is wound bed preparation? It isn't entirely new. It's what you've been doing for a long time, but is hopefully assembling these concepts into one systematic approach, that at every time a patient comes in, you can use this type of systematic algorithm and an assessment to determine if the wound bed is prepared and the wound is making progress. So again, this is an integrated approach that assesses each of the time components: the tissue, infection, inflammation, moisture, and edge. There are already 2 reports, I'm glad to say, at the European Wound Management Association meeting earlier this year in Prague, notably assessing how difficult it is to implement these concepts in a clinical situation. I point out that both of these are from the UK. You are far, far ahead of the States in terms of having uniform standards for treatment of wounds. And as I said a little bit earlier, I hope that Caroline Dowsett will have the quantitative statistical assessment of how big an impact these types of wound bed preparation concepts will actually make in wound care. So now in the last few minutes, I'm going to shift and I'm going to say what happens when you've done everything that you think you can and you have prepared the wound bed correctly and that wound margin still isn't migrating. At that point, you need to begin considering using advanced therapies. One of the most visible types of adjuvants that people are using are the concepts of topical antimicrobials. As you know, the field of topical antimicrobials was popular, fell into disfavor because of inappropriate chronic use of broad cytotoxic antimicrobials that actually damaged the wound when they weren't needed. And turned now, within the last 5 to 10 years, to the idea of using silver-containing dressings when appropriate on a wound. And I would emphasize that the best practice guidelines indicate that every wound does not need a topical antimicrobial. It is only when a wound is failing to progress and you have these assessments within the time algorithm that suggests that there may be a problem with infection and inflammation that you should consider using this very powerful but also toxic material. Silver is not selective for bacteria. It kills all cells, including mammalian cells. But it is a very effective topical agent, and this one type of I think in the United States now there are 27 different dressings that are approved that contain silver. All of these release silver. There are some that appear to have slightly different patterns and concentrations of release. In the UK and unfortunately in the US, we're catching up with you in terms of resistant organisms in our hospitals and in our extended care facilities. And particularly when an infection is responsible or due to MRSA or VRE, it is extremely important that you consider using the appropriate antimicrobial. Shifting gears, within just the last month, published in the International Wound Journal, an article by Stride, I think is important, in part because it emphasizes again the principle of this hypothesis of wound bed preparation. And Stride and colleagues actually took 8 patients with 14 chronic wounds that failed to heal from conventional therapies. Most of these were 6 months of duration or longer, some out to 30 years. And what they did was to topically apply an antibody that neutralizes TNF-alpha. And these reagents and these drugs actually come through the arthritis area. So they were developed to try to reduce the inflammation that is hallmark of arthritis, and injecting these, in this case, antibody to TNF-alpha into an